Hello, my dear students. Now we shall be discussing a very important and a very interesting topic in cardiovascular system, that is diseases of heart valves. To start with, we'll be talking about mitral stenosis. As we all know, mitral stenosis is generally rheumatic in origin. I have said this thing in my earlier presentation also, that mitral regurgitation happens to be one of the most important heart valve disorder which is associated with rheumatic fever. So mitral stenosis is generally rheumatic in origin, although in older people it can be caused by heavy calcification of the mitral valve apparatus. Please note, 2/3 of all the patients with mitral stenosis are females. This fact is important again from the MCQ perspective. There is also a rare form of congenital mitral stenosis. In rheumatic mitral stenosis, the mitral valve orifice is slowly diminished by progressive fibrosis, calcification of the valve leaflets, and fusion of the cusps and subvalvular apparatus. There may be fusion of chordae tendineae along with its shortening. The normal mitral valve orifice is normally about 4 to 6 centimeters square in diastole, and it may be reduced to 1 centimeter square in severe mitral stenosis. Again, an important fact to note from MCQ perspective, they give you an option that in cases of severe mitral stenosis, the mitral valve orifice is 6 centimeter square, 4 centimeter square, 3 centimeter square, or 1 centimeter square. So the answer is yes, 1 centimeter square in severe mitral stenosis. Patient usually remains asymptomatic until the stenosis is less than 2 centimeters square. Less than 1.3 centimeter square leads to severe, and less than 1 centimeter square leads to critical mitral stenosis. There is dilatation and hypertrophy of the left atrium. Elevated left atrioventricular pressure gradient is the hallmark of mitral stenosis. I'll try to make you understand here. Mitral valve is located between the left atrium and the left ventricle. Wherever this orifice is shortened or there is stenosis, definitely there is resistance to flow of the blood from left atrium to left ventricle, right? Because of which left atrium has to work more to pump blood into the respective chamber, that is the left ventricle. So during long-standing mitral stenosis, ultimately there is hypertrophy of the left atrium, because left atrium has to generate more pressure to pump blood across a stenosed valve. So therefore, as I have already said, there is dilatation and hypertrophy of the left atrium, and elevated left atrioventricular pressure is the hallmark of mitral stenosis. Left ventricular filling becomes more dependent on left atrial contraction. You can understand, as the stenosis progresses, the filling in the left ventricle will depend on how much pressure left atrium can generate. So in other words, left ventricular filling becomes more dependent on left atrial contraction. The flow of blood from left atrium to left ventricle is restricted, and hence left atrial pressure rises. This leads to pulmonary venous congestion and breathlessness. You can understand, as you all know, this is connected to the pulmonary vasculature. So when there is stenosis here, the left atrial pressure increases, and this increase in the pressure is transmitted backwards into the pulmonary circulation, and because of this there could be pulmonary venous congestion, and because of pulmonary venous congestion, patient might experience breathlessness. Atrial fibrillation can happen due to progressive dilatation of left atrium, and again it is very common in mitral stenosis. Atrial fibrillation can happen because of the hypertrophy of the left atrium, and so occurrence of left atrium fibrillation is common in cases of mitral stenosis. Any increase in the heart rate shortens diastole when the mitral valve is open and produces a further rise in left atrial pressure. Situations that demand an increase in cardiac output also increases left atrial pressure, so exercise and pregnancy are poorly tolerated. I hope you understand what I mean to say. Normally, the flow from the left atrium to the left ventricle occurs during the diastolic phase of the heart. Imagine when the heart rate increases, it means the diastolic time is getting further reduced. You can understand at such there is stenosis, because of which left atrium has to put pressure to pump blood into the left ventricle, and if any condition which leads to increase in the heart rate, then this diastolic time even comes down, and because of which the pressure in the left atrium increases, which could be reflected back. So any condition in which there is increased heart rate or tachycardia like exercise and pregnancy will be poorly tolerated. A more gradual rise in left atrial pressure tends to cause an increase in the pulmonary vascular resistance, which leads to pulmonary hypertension. Ultimately, because of this back pressure, there will be increased venous capacitance, there will be increase in the venous pressure, and this can give rise to pulmonary hypertension. Pulmonary hypertension leads to right ventricular hypertrophy and dilatation, tricuspid regurgitation, and right-sided failure. Ultimately, this increase in the pressure can be transmitted backwards, and ultimately this pressure increase will be reflected at the level of left ventricle also. And you know, here we have got the valve, there could be regurgitation at this level, and the pressure at the level of right ventricle will increase, and this will in turn give rise to right ventricular hypertrophy. And ultimately this right ventricular hypertrophy, further the pressure can be reflected into the right atrium and it can go back. So please try to understand, in case of mitral stenosis, it is not the problem further. Majority of the problem occurs because the pressure which is increased in the left atrium is getting transferred backwards. So problem in the venous congestion, and if the pressure is still more, it could be translated or it could be transferred at the level of the right ventricle and even can go up to right atrium, and all the signs and symptoms of right-sided failure comes. Fewer than 20% of the patient remains in sinus rhythm. Many of these have a small fibrotic left atrium and severe pulmonary hypertension. Now, what are the various clinical features which you would see in mitral stenosis? A personal suggestion from my side. It is very easy to understand the clinical features once we understand the pathophysiology, that what is happening. Because once we understand what is happening, we will come to know what could be the presentation from the patient side. Like, I'll give you an example. A very important symptom in mitral stenosis is breathlessness. Breathlessness, the reason being, as I have already said, increased pressure in the left atrium can get translated into the pulmonary venous circulation. There could be pulmonary venous congestion, and this can give rise to breathlessness. There could be fatigue. What could be the reason for fatigue? Blood is getting compromised because of stenosis of the mitral valve. So there is comparatively less output, because of which patient complains of fatigue. There could be edema, engorged neck veins, and ascites, and all these are features of right-sided failure, and I have already explained you how it's happening. Importantly, patient might have palpitations, or he might land into atrial fibrillations because of the hypertrophy of the left atrium. Patient might also have hemoptysis. I still remember, I would like to share this important point with you. When we used to study, our teachers used to ask us, just tell us 3 important causes of hemoptysis. And I still remember, we used to say mitral stenosis, pulmonary tuberculosis, bronchogenic carcinoma. Hemoptysis could be a presenting symptom in mitral stenosis. What could be the reason perhaps? It is because of the rupture of pulmonary and bronchial venous connections, ultimately leading to pulmonary hypertension. So hemoptysis could be a presenting symptom in case of mitral stenosis, which is because of rupture of bronchopulmonary venous connections because of increased venous pressure. Signs, we can get signs of atrial fibrillations. Mitral facies, this is commonly seen in mitral stenosis. What is mitral facies? We get facial cyanosis with malar flush. This typical facies is known as mitral facies, commonly seen in mitral stenosis. What would be the features on auscultation? First of all, we will get an opening snap, we will get mid-diastolic murmur, and we will get loud first heart sound. I just want to explain how this all is happening. Please understand, when the blood from left atrium comes into the left ventricle, initially as this valve opens, whatever blood has been accumulated into the left atrium comes into the left ventricle. This is the first phase. Secondly, this valve remains open. Whatever blood from the pulmonary side comes into the left atrium comes to the left ventricle. And finally, left atrium contracts and whatever blood is there into the left atrium comes into the left ventricle. So in normal condition, what happens during the third phase when left atrium has to contract, the mitral valve has almost reached its orifice back. Can you understand if I talk about, like, if I can explain you like this? In normal cases, the mitral valve opens, the blood flows. And during the third phase, this mitral valve has already traveled to this much position. And as soon as the left ventricle contraction starts, this comes up and first heart sound is produced. Is it okay? Now please try to understand, if there is mitral stenosis, at the third phase of the blood flow also, these mitral valves would be open wide apart, because there is resistance in flow of blood from the left atrium to left ventricle. So when the left ventricle contraction starts, at that point also the mitral valves are wide open, and because of the increased pressure by left ventricular contraction, these valves comes and strikes back, katak, and because of this, loud first heart sound is produced. As you can imagine, if you just shut a gate with smaller distance, and if the gate is open wide, and then if you shut it, definitely the voice which will be produced would be more. Secondly, we get opening snap. What is opening snap? Opening snap follows S2, and it is because of the forced opening of valve due to high atrial pressure. So because this atrial pressure increases, the valve opens forcibly and you get an opening snap. Thirdly, an important feature of mitral stenosis is we get a mid-diastolic murmur. You can understand why it is mid-diastolic. Recall cardiac cycle. Blood from the left atrium flows into the left ventricle during which phase of cardiac cycle? Yes, it is the diastolic phase where the left ventricle is getting filled. Only when the left ventricle is getting filled, at that time blood is traveling from left atrium to left ventricle, and at that time only it comes in contact with the stenosed valve. And because of this stenosis, a turbulence in the path of the blood is produced, and because of this turbulence, mid-diastolic murmur is produced. So this is the reason why we have loud first heart sound, we have opening snap, and we have mid-diastolic murmur. You should understand the length or the duration of the murmur tells you about the severity of the mitral stenosis. Now, most of the time in the MCQ, there will be a point that what tells you about the intensity or the severity of mitral stenosis. Definitely the length or the duration. You can understand if the valve is very critically stenosed, right? This passage of blood will take more time. So more time blood will take to come into the left ventricle, and because of this the duration of the murmur will be more. So more the duration of the murmur, it gives you an idea that the severity of the mitral stenosis is high, or mitral stenosis is very severe. So three important points, as I have already said: loud first heart sound, second is opening snap, and third is mid-diastolic murmur. Other clinical features which you see in mitral stenosis is you can get cough because of pulmonary congestion, you can get chest pain because of pulmonary hypertension, you can get thromboembolic complications, example mild stroke, ischemic limb, or certain books also say you can get hoarseness of voice. Can you just think how mitral stenosis can give you hoarseness of voice? Yeah, at times the left atria, which is hypertrophic, it impinges onto the recurrent laryngeal nerve, and because of it, in certain cases of mitral stenosis, certain books says that you can get hoarseness of voice. You can get crepitations, pulmonary edema, and effusion, and all this is because of the raised right ventricular pressure. Ultimately, you can get right ventricular heave, and there is loud second heart sound. That is, the P2 component of S2 is loud, and this P2 is loud because of the accompanied pulmonary hypertension. What are the investigations which we would like to do in cases of mitral stenosis? First is ECG. ECG will show us P mitral, which means we get bifid or tall P wave. or we can get signs of atrial fibrillations also. Definitely there would be right ventricular hypertrophy, and this right ventricular hypertrophy will be shown as tall R waves in V1 to V3, and because of the right ventricular hypertrophy you can get right axis deviation in an ECG. What will chest X-ray show you? Enlarged left atrium. You have understood, because of this stenosis, left atrium has to generate more pressure, because of which ultimately slowly left atrium undergoes hypertrophy. There is right ventricle enlargement, again because of the transmission of the back pressure. There is straightening of the left heart border, and in older books they have mentioned that this condition in which we get straightening of the left heart border, this condition is known as mitralization of the heart. Thirdly, we can get Kerley lines and signs of pulmonary venous congestion, which is nothing but only because of the reflection of the pressure back into the pulmonary circulation. A Doppler study will show you pressure gradient across the mitral valve. Doppler study will show you pressure gradient across the mitral valve, because definitely the pressure gradient at this level would be high. Doppler study will also give you an idea of the size of the mitral orifice, that whether it is severe or it is critical mitral stenosis. It also gives you the extent of restriction of valve leaflets. It also gives you an idea of pulmonary artery pressure, left ventricular functions, and if you are doing a Doppler study, it can also give you an idea of any associated cardiac valvular lesion, like some pulmonary or other associated lesions. What will be an echocardiogram show you? Echocardiogram happens to be the most specific and sensitive non-invasive method to diagnose mitral stenosis. Now please try to remember this point. In various MCQs, they will be giving you options that which is the most specific and most sensitive method of diagnosing a valvular lesion. Yes, the answer is echocardiogram, which will show you the thickened immobile cusps, which will show you the reduced valve area. It will also show you the reduced rate of diastolic filling of left ventricle, and importantly, please understand, please remember, an echocardiography will show you enlargement of left atrium, which is the hallmark of mitral stenosis. So it is easy. This enlargement, back pressure, loud first heart sound, opening snap, and the mid diastolic murmur tells you most about mitral stenosis. If you want to do cardiac catheterization, which will give you an idea of pulmonary artery pressure in cases of pulmonary hypertension, it will also give you an idea of associated coronary artery disease, and it will also show you if there is any associated regurgitation. So importantly, you should remember echocardiogram, the most sensitive and specific non-invasive method to diagnose MS, or in broader words, valvular heart disorders. I have kept this slide specifically because atrial septal defects, the clinical presentation of atrial septal defect could mimic mitral stenosis in a very big way. I have kept this slide specifically because atrial septal defect can give you clinical presentation which would mimic mitral stenosis in a very big way. In both the conditions, there is clinical, radiologic and electrocardiographic evidence of right ventricular enlargement and accentuation of pulmonary vascularity. As you all know, what is atrial septal defect? Defect within the interatrial septum. So ASD and MS, that is mitral stenosis, gives rise to overlapping clinical features. So we need to understand that how to differentiate between both these two important clinical conditions. In both the conditions, you get wide split S2, which can be confused with OS. And as I just want to tell a few words about S2. As we all know, there is first heart sound, which is because of the closure of the mitral valve, and then we have got the second heart sound, and this second heart sound has got two components, the A2 component and P2 component. This A2 component comes because of the closure of the aortic valves, and yes, P2 component comes because of the closure of the pulmonary valves. In case of atrial septal defect, there could be splitting of second heart sound, and this splitting it can be confused with opening snap. In both the conditions, you get diastolic murmur across tricuspid valve. So what I just want to tell you is that the clinical presentation may be so confusing that you can misread ASD for MS or MS for ASD. So what's to be done? Importantly, in ASD, there will be no left atrial enlargement, as I have already said in my initial part, that left atrial hypertrophy is the hallmark of mitral stenosis, whereas in case of ASD, there will be no left atrial hypertrophy. There will be absence of Curley lines, because Curley lines are nothing which tells you about pulmonary venous engorgement. So Curley lines will not be there in ASD, and there will be fixed splitting of S2, which favors atrial septal defect. So there are three important points. If there is ASD, there will be no left atrial hypertrophy. There will be no Curley lines, which is giving you an idea about pulmonary congestion. And please remember, fixed splitting of second heart sound is seen in atrial septal defect. Similarly, left atrial myxoma can also present with same signs and symptoms as mitral stenosis. Echocardiography. Importantly, echocardiography in left atrium by 2D echo. If you do 2D echocardiography, you can see a left atrial mass in case of left atrial myxoma, which will not be present in case of mitral stenosis. So this is how you differentiate between two important clinical conditions. There might be an MCQ which tells you only one thing, A, B, C, D, right? You might think that this could be ASD. But if you are looking for ASD, see for the fixed wide splitting of second heart sound. And if you are looking for mitral stenosis, please look for left atrial enlargement and signs and symptoms of pulmonary vascular congestion. How to manage such cases? Patient with minor symptoms should be treated medically. Prophylaxis of streptococcal and infective endocarditis is important. Oral diuretics will take care of the pulmonary congestion. Small doses of beta blocker can control the ventricular rate in atrial fibrillation, and measures to reduce pulmonary venous pressure will be of help. Intervention by balloon valvuloplasty, mitral valvulotomy, or mitral valve replacement should be considered if the patient remains symptomatic despite medical treatment, or if severe pulmonary hypertension develops. So you can manage the patient medically by giving diuretics, small doses of beta blocker and other things. But if the condition deteriorates, then definitely you have to go for a surgical intervention. Mitral balloon valvuloplasty and valve replacement is the treatment of choice, although surgically closed or open mitral valvulotomy are acceptable alternatives. Patients who have undergone mitral valvuloplasty or valvulotomy should be followed up at 1 to 2 yearly intervals, because restenosis can occur. So you have to follow these patients for a period of time. Clinical symptoms and signs are a guide to the severity of mitral restenosis. And importantly, as I have already stressed, and again I am stressing this important point, Doppler echocardiography provides a more accurate assessment. Okay students, so you have seen what could be the clinical presentation of mitral stenosis, what are the other associated features which can mimic mitral stenosis, which can confuse you, or examiner can confuse you by giving relevant options. So please take a note of this: loud first heart sound, opening snap, mid diastolic murmur in mitral stenosis, and fixed splitting of S2 is hallmark for atrial septal defect. Thank you.